Ladies, can you hear me? Okay. All right. Oh, okay. Okay, can you unmute yourself and tell me if the slides are moving?
Yeah, they're moving.
Good, okay. Sometimes, for some reason, the slides don't move, and I'm not sure why. Okay, it's 8 o'clock. We'll go ahead and get started then. I apologize for some of the pictures today. They're going to be a little hard to put together with your breakfast. So Still yourselves as best you can, and let's go ahead and talk about skin infections. First, a word of prayer. Dear Lord, thank you for this cold day. Thank you for the chance to go to school, even though we're on partial lockdown. We pray for those in charge of our government that you give them wisdom. For those of us on quarantine, help us withstand the quarantine. For those sick with COVID-19, please heal them quickly. And most of all, Lord, for everyone here today, please help me to be clear today. Please help learners to learn well. The time we use today would be well used. In Jesus' name we pray. Amen. All right, if at any time something goes south, let me know. If you send a text, the chances I'll see it in the midst of the lecture are not high. So go ahead and unmute yourself and say something. Say your audio is not working, your slides aren't working, something like that. And we'll go on. Okay, so if we consider the skin, we have various denizens of the skin, and the biggest denizens are, of course, members of the genus Staphylococcus. So the Staphylococcus aureus and Staphylococcus epidermidis. Staphylococcus aureus can acquire new genes by means of transduction, so by means of phage, by means of conjugation, that is, by means of plasmids, and by means of transformation, whereby it can take up genes from other bacteria. All of those newly acquired genes can play a role in its ability to cause disease. So probably the most common disease caused by Staphylococcus aureus is an infection of the hair follicles. And if they infect these hair follicles, they cause a very localized infection. It is very restricted to this particular anatomical structure, namely the hair follicle. So in those cases, it causes a so-called folliculitis. So folliculitis is a superficial infection of the hair follicle, doesn't go very deep, tends to resolve on its own. And if you have a folliculitis, usually washing these with benzalkonium chloride or something like that, using antibacterial soaps, usually will clear these up quite well. Now, there's a different type of folliculitis, and I'm going to go ahead and now use my other camera. And this is called a hot tub folliculitis. Oh boy. Is my light on? Boy, that's not very much light. Okay. Hot tub folliculitis. Hot tub folliculitis is just what it says it is. You have an infection that usually ensues after your patient has been in a hot tub. This is not caused by Staph aureus. This is usually caused by Pseudomonas aeruginosa. Hot tub folliculitis does not, instead of having individual hair follicles that are infected, that are restricted to certain parts of the body, the face, the growing, the axilla, the trunk, places like that. These are usually found all over the body, usually the trunk. Also with these, they just tend to be red and they tend to be flat. Red, and they tend to be flat. Hot tub folliculitis usually will self-resolve. So usually with hot tub folliculitis, you're not going to need to treat it. All right, let's go back then to the slides. So if you have a larger group of follicles and the infection is much deeper in the follicle so that it goes down into the dermis, and so you now have this welt-like structure, that is called a furuncle. A furuncle. And here's a picture of a furuncle on your left. You can see this is indurated, it is tender, it is raised. You tend not to get systemic sorts of symptoms, usually with a furuncle. They're pretty restricted to the one particular spot on the body. Now, if you have groups of furuncles that are all together, then you have a so-called carbuncle, a carbuncle. And now these carbuncles, because you have infections of groups of these follicles, so the group folliculitis, you have something that's a bit more severe. You may have systemic sorts of manifestations with the carbuncle. So you may have a fever, you may have some sort of malaise or something like that with these, or you may not. It depends on the size, depends on several other things. It really depends how widespread these is, so on and so forth. So furuncles usually not going to have very much of a systemic manifestation. With carbuncles, you might. These are usually treated topically. So usually you're going to use 1% clindamycin 2 times daily as needed. You may use 2% erythromycin, or you might use a compound we didn't really talk about in class called mupirocin. Mupirocin is spelled M-U-P-I-R-O-C-I-N. Mupirocin. You usually use a 2% ointment, and you'll usually apply it 3 times a day. There is also another ointment that is used typically for these types of things as well. It's called retipamelin, and it's not hugely available in the US. So mupirocin is usually what you're going to use for these types of things. So these, again, they're deeper in the skin, they're deeper in the dermis, they're more widespread, and they're usually spread out. Now, if we go back, we can see that some strains of Staphylococcus will express these toxins called exfoliatins. Exfoliatins. The exfoliatins are going to degrade some of the layers of the, some of the proteins that hold the layers of the epidermis together. So there's a protein called desmoglein 1, and desmoglein 1 so usually you have, remember the layers of the skin, you have the stem cell layer down here, the stratum basale. So these cells will divide, and they will give rise to a so-called stratum spinosum. These cells will start to kind of be a little less regular in their shape. So this is the stratum basale. And then this is the stratum spinosum. And then that's better. Then you get the layer above that, which is the stratum granulosum. Now the cells start to make these little granules, and the cells really start to get kind of more like this. And you can start to see the keratin granules starting to form in these. So that's the stratum granulosum. So these are held together by these junctions. And these junctions are formed by a protein called desmoglians. So desmoglian 1 is degraded by this exfoliatin. That's made by some strains of Streptococcus. They will cause, therefore, the epidermis to lift off itself, and you'll get these rather large blisters. Now, these blisters don't go down to the dermis. They just involve the epidermis. So these blisters sometimes can look awful. And you can see them here. And usually these will appear essentially in babies, particularly in newborns. It's not uncommon for the newborn to get the infection from the mother. The blisters will start usually about 1 to 3 days after the acquisition of the infecting organism. They will usually form around the growing, the axilla, and the mouth. The skin will peel, and you get these exposed areas that are red. They're moist and they're tender. The patient will usually be irritable. They may have a fever. If the patient is a young child rather than an infant, they may also have a sore throat and a UTI as well. You can culture this from either skin snips or a swab of the focal area. Treatment is usually supportive and includes topical moisteners. Topical antibiotics might be used, but these usually, you get these large blisters, and these large blisters pop, and again, they look really awful, but they heal without any scarring because they don't involve the dermis. If you really need to treat these, the issue comes up if they're caused by methicillin-resistant Staphylococcus aureus. In that case, then you'll need to treat with either vancomycin and maybe clindamycin, or you might use linezolid, or a combination of vancomycin and clindamycin or linezolid. If your patient itches, you can use antihistamines like hydroxyzine to quell the itching. If the patient has nasal carriage of the Staphylococcus, you might get a relapse. So in that case, you need to treat with nasal mupirocin for 7 days. And you might also need to treat with washes with the antibacterial chlorhexidine, 0.2% chlorhexidine. If you work in labor and delivery, you'll probably see scalded staphylococcal skin syndrome. That's what this is called. SSSS, scalded staphylococcal skin syndrome, or staphylococcal scalded skin syndrome, either one. They're caused by strains of Staphylococcus aureus that express exfoliatins. Very good. All right, so now we can see the furuncles and the carbuncles, and you can get the furuncles and the carbuncles are kind of different manifestations of each other. The carbuncles being more severe than the furuncles. Cellulitis is an infection of the subcutaneous level. So if you consider the skin, we go way back here to the skin. So the scalded staphylococcal skin syndrome only affects the epidermis. Your folliculitis affects the hair follicle. If you go deeper into the dermis with the hair follicle infection, that's a furuncle. If you get the furuncles fusing, then you have a carbuncle. If you have an infection down here in the adipose layer underneath the dermis, that is essentially cellulitis. Cellulitis can be severe. Cellulitis will typically follow a break in the skin. It's a result of bacterial entry via the skin. Staphylococcus aureus isn't the only organism that can cause cellulitis. It's probably the most common cause of cellulitis. Predisposing factors would be obesity or immunosuppression, as in the case of diabetes mellitus or HIV infections. If you have a pre-existing skin condition of some sort, chicken pox, of wingworm infection caused by fungi, some sort of skin inflammation condition like eczema, which will cause skin breaches, that can predispose you to cellulitis. It's not uncommon for people with cellulitis to have systemic manifestations, fever. You might have lymphadenopathy. And these can spread. And if they spread, they can cause things like osteomyelitis. One of the big complications of cellulitis is if you get cellulitis around the orbit of the eye, because that can cause damage to the eye. It can also cause the eye to bulge out. That's called proptosis. It can also cause ophthalmoplegia. And ophthalmoplegia means you have a paraplegia of the eye, essentially. The eye has trouble. The eye is paralyzed. You can't really move it. If you get an abscess because of cellulitis, remember, abscesses need to be surgically removed. You can't remove abscesses just with drugs. You'll have to remove them surgically as well. Here's an example of orbital cellulitis. If this leads to some sort of abscess, that will need to be drained. You have to be very careful, of course, when you're working with the eye. So cellulitis, if you have an abscess, it's a good idea to do a ultrasound to see the abscess. For orbital cellulitis, a CAT scan is usually used to see the involvement of the eye. Treatment is going to depend on whether or not your organism causing it is a methicillin-sensitive Staphylococcus aureus or a methicillin-resistant Staphylococcus aureus. If you have a methicillin-sensitive Staphylococcus aureus, then you treat with dicloxacillin, cefadroxil, or cephalexin, dicloxacillin You know what? Let me write these down because I think it'll be easier for everybody if I write these down for everybody. So if the cellulitis is caused by methicillin-sensitive Staph aureus, then dicloxacillin is used, so is cefadroxil, and is cephalexin. I'm sorry, PH, not F. Cephalexin. If you have a methicillin resistant Staphylococcus aureus, usually it's going to be vancomycin. Vancomycin, remember, is always given intravenously unless you're trying to treat some sort of GI condition, because this is not absorbed if you give it in the GI tract. Other regimens may include Bactrim. That, of course, Bactrim is trimethoprim and sulfamethoxazole. Linezolid is another possibility as well for MRSA. These drugs, of course, are oral. Another test you can do for cellulitis is to do a punch biopsy. Usually you don't wait for the results of the punch biopsy before you start treating, but this can essentially help you identify the organism if all else has failed. Keep in mind, 75% of cellulitis are caused by Staph aureus, but they can also be caused by Streptococcus, and they may be caused by other types of organisms as well. Okay, if vancomycin doesn't work, you can also use, there's another drug that is used for MRSA, and that is daptomycin. That's very useful against MRSA as well, daptomycin. Okay. If you have an orbital cellulitis, you may need to treat the organism with ointments to the eye as well. And some of these drugs come in ointments that you can use, others do not, so you have to be careful. Erysipelas are caused by Streptococcus pyogenes. Streptococcus pyogenes. These are infections of the deep dermis, so they're kind of, sort of like cellulitis. You can see they cause a very bright red sort of erythema. They almost always cause systemic conditions as well. And these are treated, if you're using uric treatment for a erysipelas, you almost certainly will treat them with many of the same antibiotics that you might use for methicillin-sensitive Staphylococcus aureus. You'd use cefazolin or ceftriaxone or clindamycin, or you might combine clindamycin with cefazolin or ceftriaxone or something like that. So urocephalus, again, are usually caused by breaks in the skin, if you suspect methicillin-resistant Staph aureus, usually on top of these you would add vancomycin, usually as well. If the person has a beta-lactam allergy, then it's usually clindamycin, 450 mg 3 times a day, usually. Scarlet fever is usually a sequela of strep throat, usually. So the scarlet fever usually produces some sort of rash. This rash is due to the elaboration of a so-called erythrogenic toxin. Erythrogenic toxin. This toxin causes widespread hemolysis of blood vessels, and that's what causes the rash. The tongue will have a so-called white strawberry appearance. You have sometimes a little white coating on the tongue, and you can kind of see the white coating is typically in the back of the tongue, back here, and then this tongue kind of gets this strawberry color. Then the rash will usually appear as well. Again, this occurs after, usually you have a pharyngitis infection. The rash will begin 1 to 2 days following the onset of the pharyngitis. So the rash, as you can see, is this diffuse redness of the skin with these small papules or bumps. They kind of resemble goosebumps. The skin has a sandpaper quality to it. It starts usually at flex points in the body, starts at the flexion of the elbow and other surfaces, excuse me. It'll usually spread then to the trunk. The face is usually spared. Usually. Face may become flush. You may get these lines that appear in a linear fashion. These are called Pastia's lines. Pastia's lines. And the rash fades usually within a week, followed by a process of peeling of the skin. That's called desquamation. Desquamation. Scarlet fever occurs most often in kids. So if any of you work peds or family medicine, you'll almost certainly see scarlet fever. Many of the strains of Streptococcus pyogenes that cause scarlet fever are still susceptible to early generation beta-lactams. So penicillin V, which is taken by mouth, is a good choice. Amoxicillin comes in a liquid form and is equally effective if the kid can't swallow tablets. You treat for 10 days. Benzathine penicillin G, given as a one-time shot, is an option as well. Status being used less and less. So an alternative would be clindamycin or erythromycin. Fluocinolone drugs are not recommended anymore because of rather widespread resistance to fluoroquinolones. The treatment for this is usually supportive. Once antibiotics have been given, the toxin will stop being produced. That's why sometimes clindamycin is given with the beta-lactam antibiotics because it quells toxin production. Impetigo is an infection of only the epidermis. 9 times out of 10, impetigo is a mixed infection that consists of Staphylococcus and Streptococcus. Impetigo is very highly contagious. Usually starts on the bridge of the nose. You get this wet red skin that'll crust over. The scab will fall off and resolve without scarring. That's pretty common because it just affects the epidermis. Open wounds near impetigo may lead to cellulitis. This is observed most often in children. This gets passed around daycare centers very, very commonly. These are also subject to secondary infections. So you also want to try and keep these clean. You also may see these at spots of secondary trauma. So abrasions, insect bites. They're frequently observed in kids ages 2 to 5, although older children can get them, so can adults. It usually occurs in warm, humid conditions and is spread by close contact. Risk factors include poverty, crowding, poor hygiene, and underlying scabies. There's 2 types of impetigo. There's non-bullous and bullous impetigo. Bullous impetigo is seen on your left. This is seen primarily in young children. The vesicles enlarge to form these bullae or blisters with a clear yellow fluid that becomes darker and more turbid. They will rupture and leave a thin brown crust. There are usually fewer lesions than in non-bullous impetigo. The trunk is more frequently affected in bullous impetigo. And adults with bullous impetigo should prompt some sort of investigation for immunosuppression. Bullous impetigo is often due to strains of Staph aureus that produce exfoliative toxin. Non-bullous impetigo is definitely the most common form of impetigo. The lesions begin as papules that progress to vesicles surrounded by red spots, surrounded by erythema. They enlarge, they rapidly break down and form these thick, adherent crusts with kind of a golden appearance. They usually occur over a period of about a week. The lesions involve the face and extremities. They develop but tend to remain well localized. And systemic sorts of symptoms are usually absent in the case of non-bullous impetigo. Treatment of impetigo is almost always restricted to topical treatments. So again, 2% mupirocin, usually 3 times a day for 5 days, clears it up quite well. You can treat it orally with cephalexin. If MRSA is suspected, then trimethoprim sulfamethoxazole is used, or doxycycline, or clindamycin. Oral antibiotics should be considered for cases with multiple lesions or outbreaks that affect multiple people. In people with limited number of lesions, oral and topical antibiotics are equally effective. Now, toxic shock syndrome is a exotoxin-dependent syndrome caused mainly by Staphylococcus aureus, but also by Streptococcus pyogenes. About half the cases are due to people using tampons that are contaminated with toxic shock-secreting microorganisms. So it's not due to an infection, it's due to a toxemia. The organisms are able to colonize the tampon. When the tampon is inserted, this toxin will penetrate the vaginal wall. The toxin is a so-called super antigen. Super antigen. Let's talk about a little bit about a super antigen. We didn't get to talk about that in immunology. So let's say you have a antigen presenting cell. That antigen presenting cell is using its MHC class II protein to present some sort of antigen to a helper T cell. And then the helper T cell has the CD4 molecule here. So this is the T helper cell here. Here's your CD4. Here's your T cell receptor. This is MHC class II. Super antigens are able to bind to the T cell receptor and to the MHC protein and form a bridge like this. So normally this cell has all these checks on it. You have to have the CD4 protein involved. You also have to have CD28 and B7 involved as well. This, however, bypasses all that. That means these super antigens will activate low numbers of T helper cells, and they will do so in an unrelated fashion. So you get huge number of cytokines. Large quantities of cytokines will be made. That is going to cause shock because you experience so-called capillary leak syndrome. And now your capillaries These cells now are going to shrink. They're going to become very leaky. You're going to get fluid, and protein flows out into this, and so your blood pressure is going to tank, essentially. So this is essentially what happens with toxic shock syndrome. You go into shock. So now your shock protocols now have to essentially come into play here. So you get large release of interleukin 1 and 2 and tumor necrosis factor and interferon gamma. You have these signs and symptoms essentially. You have initially a high fever. That's due to high interleukin 1 release. You have vomiting and diarrhea, headache, muscle pain. You'll have a sunburn-like rash, redness in the eyes, mouth, and vagina. And then the blood pressure will start to tank and the patient may even lose consciousness. Treatment was supportive, also with antibiotics. So you have to give, first of all, fluid support. Fluid support is essential. Patients may need up to 10 to 20 liters per day to maintain perfusion because of somewhat intractable hypotension and diffuse capillary leak syndrome. Vasopressors such as dopamine and norepinephrine might be required. And then you need to give clindamycin as the drug of choice because it prevents toxin production. If MRSA is suspected, then you add vancomycin. Secondary agents include linezolid. And if the infected organism is a methicillin-sensitive Staph aureus, then you can use oxacillin, intravenous oxacillin or nafcillin. Corticosteroids have been given, but there's very limited clinical data favoring the use of corticosteroids. Intravenous immune globulin has been given as well. There are case reports showing this works, but the actual data showing that this works is pretty limited. So there just aren't any controlled clinical trials of intravenous immunoglobulin to treat toxic shock syndrome. So burn infections are very commonly colonized with various types of microorganisms. These burn infections can be a genuine bummer to treat. One of the things you need to do away with a burn patient is, first of all, address the circulation in the area because the burned areas have collapsed a lot of the blood vessels. So the way to uncollapse those is to debride the burned area. Then also very aggressive fluid support is essential. And then also wrapping your patient in the burn blankets, the cooling burn blankets to make sure that they can maintain their body temperature. You'll notice that this burn infection here has a greenish tinge. That's due to a pigment called pyoverdin. Pyoverdin, P-Y-O-V-E-R-D-I-N-E. This is a green compound that is an iron grabber, an iron chelator. This is secreted by infecting Pseudomonas aeruginosa. If you see this greenish tinge, that is a sure sign you have a Pseudomonas aeruginosa infection. Pseudomonas aeruginosa secretes a very powerful exoxin A. This is a powerful inhibitor of photosynthesis. Pseudomonas, like Staphylococcus, can form biofilms. It's a slime of extracellular carbohydrate that the organism hides in. It makes it difficult to treat because it's hard to get antibiotics into it. You will need to treat this usually with anti-Pseudomonas antibiotics. So that will include things like piperacillin and tazobactam. Pseudomonas have quite a bit of antibiotic resistance. They tend to be resistant to aminoglycosides. However, if you combine aminoglycosides with a beta-lactam, you may find yourself having some sort of synergy between the two. So if you have a Pseudomonas infection, you usually have to pull out the Pseudomonas specific drug. Ceftazidime, the third generation cephalosporin, ceftazidime is a Pseudomonas specialist. You can use that drug as well. But piperacillin tazobactam is usually your go-to drug for that. Other organisms that can cause burn infections, Serratia marcescens. Serratia marcescens makes a red pigment. You'll usually see a reddish tinge on the wound. Serratia marcescens is very resistant to lots of different antibiotics. And so usually carbapenem type antibiotics are used, or ticarcillin and clavulanate are used. Ticarcillin and clavulanate. And then Providencia is another organism that can affect burns. That organism too has become very resistant to a variety of antibiotics. So burn patients, again, you have an eschar, a blackened area that needs to be debrided, and then you need to consider skin cell replacement using cultured skin. Okay, let's talk about some of the viral infections that infect skin. First, are there any questions on any of the bacterial skin infections? Okay, if there are none, we will now move on to the viral skin infections then. And we will start with rubella. So rubella, or German measles, most commonly occurs, if it occurs at all nowadays, occurs in children. 5 days before the appearance of the rash, and the rash is usually going to appear 2 weeks after exposure, at least children. You'll usually have a low-grade fever. In adults, you'll have headache and usually pink eye, cough and runny nose. In children, you may not have any of that. The virus initially infects the body through aerosols and droplets. It then spreads. You have a viremia, usually. Tends to cause a vasculitis, and that's what seems to be responsible for the rash. In children, the rash will usually last only about 3 days. Starts on the face. Sometimes it's itchy. Swollen lymph nodes are common. The rash is small pink or red bumps. They all appear at the same time. They spread downward to the trunk and limbs, and then it clears up. Teenagers and adults who get rubella are more likely to be sick for a longer period of time. A sequela of this is usually arthralgia and arthritis, or pain and inflammation in the joints. That's more common in females. The joint issues will last usually about a month or longer. Rubella during pregnancy increases the risk of miscarriage, fetal death, or stillbirth. Neonates born with congenital rubella syndrome have a triad of symptoms, usually hearing loss, eye abnormalities like cataracts or retinopathy, and congenital heart disease, such as patent ductus arteriosus. They're also born with so-called dermal extramedullary hematopoiesis, which red blood cells are formed in the skin rather than the bone marrow, and that produces red or purple spots on the skin called blueberry muffin rash. Congenital rubella is associated with decreased intellectual capacity, developmental delays, behavioral disorders, skin lesions, diabetes mellitus, enlarged liver and spleen. It's really quite sad. And as you can see in the graph here, congenital rubella has been driven to extinction with the onset of the vaccination. So this is a very good antidote to anyone who says that vaccines don't work. And very often the pregnant mother has no idea that she has the disease. Measles is an exceedingly contagious disease. If one person in a room has measles, 90% of the non-immune people in the room will also get measles. It will infect the epithelial cells of the trachea or the bronchi. It uses a hemagglutinin on the surface, otherwise known as a H protein. It binds to a target receptor called CD46, which is found on all nucleated cells. It can also infect immune cells, antigen-presenting cells, B or T cells, by using a different signaling molecule called CD150. These cause the membrane of the virus to fuse with the cell. It gets picked up by dendritic cells and alveolar macrophages. From there, it spreads, gets in blood, spreads to other tissues like the intestines and the lungs. That takes about 10 to 14 days. This is the incubation period. We enter the prodromal period that lasts about 3 days. That's characterized by high fever and the 3 C's: cough, conjunctivitis, and coryza. Coryza, C-O-R-Y-Z-A, coryza. That's the swelling of the mucous membranes of the nose and essentially a stuffy nose. The mucous membranes of the nose will look like salt grains on a wet background. And these are the so-called Koplik spots. They're seen on the cheeks, just opposite the molars, that you can see them here. This is called the so these prodromal symptoms, after these comes the exanthem phase. The exanthem phase. This includes a red macropapular rash that spreads in a head to toe progression. The rash will fade after about 4 days, and then a recovery phase will last for 10 to 14 days, the final symptom being a persistent cough. And so the infected people usually will continue being infectious for about another 4 days or so. Once you have measles, you have lifelong immunity. Measles, however, can also suppress the immune system for 6 weeks. That leaves people susceptible to bacterial superinfections. If you are a child under 2 years of age, you're at higher risk for acute sclerosing panencephalitis. That can happen 7 to 10 years later. This is thought to be caused by a persistent measles infection that leads to chronic infection of the brain. That'll cause seizures, coma, and if left untreated, death. Diagnosis of measles is done by serology. However, vaccination has driven this disease to near extinction. You still see it in people who don't vaccinate their kids. And let's be honest, for no good reason. Measles cases, unfortunately, are spiking in this country and in the United Kingdom because of vaccine denial. And it looks like, well, I have 2 minutes left according to my watch. I probably have enough time to talk about roseola. Roseola is caused by human herpes virus 6. This is a double-stranded DNA virus. It is passed by respiratory secretions. Once in the body, the virus attaches to dendritic cells. It will then infect T cells. It infects T cells the best. Once inside T cells, they will undergo a phase. The virus can replicate in a wide variety of other cells, but not as effectively as inside T cells. Then it goes into a latent phase in those sites where the virus just kind of hangs out. People with immunosuppression, especially after bone marrow or organ transplants, can reactivate the virus. Most often in young children, you get a disease called roseola infantum. Roseola infantum tends to occur between 6 months and 2 years. Disease has an incubation period of 1 to 2 weeks. Disease diffuses with a high fever and may last for 3 to 5 days. During the febrile phase, the patient will have periorbital edema, acute otitis media, rhinorrhea or a runny nose, cough, vomiting and diarrhea, and also adenopathy of the lymph nodes of the face and neck. Then you get small spots on the palate and uvula called Nagayama spots. Then after the fever goes away, the rash will then develop. Rash will last for 1 to 2 days. and it may go away in as little as 2 to 4 hours. It's usually diagnosed based on clinical findings. Fever is controlled with Tylenol, and it goes away without treatment. In immunosuppressed patients, you'll treat with virals like acyclovir or ganciclovir. We're out of time. We'll start next time on chickenpox and go from there to the other skin diseases. And then if we finish, we'll move to chapter 21. Okay, I will see you guys all on Friday at 7:45.